and hit. And I'll start screen share for you, Mandy. Let's see. All right. Are you okay with starting on this case? I'm happy to, we have 3, so I'm happy to switch around if you have.
That's fine. I figured you'd go in order.
Yeah, exactly. Awesome. I'll turn it to you now. Thank you.
This is one of our 40-year-old male patients that we have. He's had diagnosis for a long time, but just didn't seek any treatment. He started using marijuana at a younger age and then just progressed slowly as he got older to other things. He has been clean for several years now, and then he had a relapse a couple years ago, but he's been clean 2 years now. He has other comorbidities that are starting to cause him issues, so he's just concerned with generally doing better with his health as a whole. His sugar has gotten worse over the years and his high blood pressure. So he's, I guess, trying to be healthier now at 40. So he did have an ultrasound scheduled in April where we had the WVU switch and everything. They wouldn't accept him for his ultrasound because he needs an updated ID. I guess it's expired. So he had to reschedule his ultrasound, and they're all the way out into August right now. So I don't have any results from that yet. His diabetes management is better since he's been taking his medicine like he's supposed to. He wasn't very compliant. He lives with his mom now, so I think she kind of makes him be better. His labs really weren't that bad. That his fibrosis stage was a F3, which was why we had scheduled that scan. His viral load is pretty high. He's like got the a MEL score of 7. So with him, we were kind of trying to push him to do his treatment to get his treatment done. But you know, like with everything else, it's hard to keep them wrangled, I guess, to do their labs like they're supposed to. He did have his vaccines like he was directed to, and he really didn't have anything other significantly except for the, you know, fibrosis score being so high. So we were thinking that Maverick would be a good option, but we wanted to see with his liver at the stage it's in, if that's what you guys thought. So
Excellent. Thank you so much for presenting that case. Any clarifying questions from the group for Mandy? And feel free to unmute or chat in. I'm happy to read out any chats that come through. Dr. Gilfus, I saw you unmuted there.
Well, I was going to see if anyone else wanted to talk first, but yeah, I guess 20 years of disease. So he fits in that natural history where he's actually progressing, unfortunately, towards cirrhosis. Interesting things on him were the diabetes to me. So remember that relationship, everybody on the call, the sort of negative relationship between diabetes and Hep C. So Hep C is more likely to make you have issues with glycemic control, more likely to cause diabetes, frank diabetes, and that can be either through the inflammatory milieu or direct insults to your pancreatic islet cells. And then diabetes, after established in poor control, can exacerbate and accelerate fibrosis. And so there's this mutually deleterious impact of concomitant diabetes and Hep C. And he also has hypertension at a young age. And so remember, another reason to treat Hep C is to reduce the chronic inflammatory state that exacerbates cardiovascular risk. And so he's already got a couple hits for cardiovascular risk. And so you're going to really want to treat him. So not only are you going to want to treat him because of the Hep C and his progression towards cirrhosis, but you can impact his cardiovascular risk and, in fact, his diabetes control. Now, looking at his hyperglycemic agents, metformin, Jardiance, and Trulicity, None of those are really high risk for hypoglycemia, as far as I remember. Rachel, you can correct me if I'm wrong, or anybody else on who's closer to diabetes management than I am. But I think those are all pretty safe. Do remember that there are anecdotes and case reports of people on insulin and sulfonylureas, drugs that are more likely to cause hypoglycemia, that when you treat their hep C, that you can actually potentially have better glycemic control and therefore less requirements for your diabetes meds, which is pretty cool. The only other thing, yeah, so HCC screening is a must, kind of forever. And then Rachel can probably touch better on the risk of Pepsid if you went with Epclusa, but of course with Mavorite, nothing you gotta worry about in my mind. And that's all I got. I'll turn it over to anybody else. But I can never remember, Rachel, if you want to do the Epclusa with Pepsid, is it the same time or opposite or something?
So if you would go with the Epclusa with that Pepsid, the dose is okay. Usually the recommendation is either, it depends really on what time they take it. So if they're doing it once a day or twice a day, so it's either take it at the same time or separate it by 12 hours. So if they're taking it once a day, they can do it at the same time or separate it. If they're taking it twice a day, then they can go ahead and just take it with their Pepsid dose. The duration of action and the pharmacokinetic studies as far as the interaction goes demonstrate that administration kind of avoids the drug interaction there, where it makes the Epclusa not work as well. So those would be the recommendations for those. The Jardiance has a hypothetical sort of interaction with Epclusa, where the concern is that the Epclusa would actually, it's the valpattocere component, make the or increase the concentrations of the Jardiance. I've had people tolerate it pretty well and not have major issues. I always just do the counseling with, checking your sugars and do you know what the signs and symptoms of low blood glucose are and those sort of things. But like you said, these ones aren't usually the ones we're super concerned with from a hypoglycemia standpoint.
Overall, this is thank you, Rachel, by the way, very, very useful. This is a great patient to treat. I mean, he's a high risk 40-year-old. He's heading the wrong way with a lot of chronic comorbidities. And so getting that one off the table is a great idea. So good catch, good find, and a good time to treat him, hopefully. I personally don't care if it's Mavorite or Epclusa. I'd probably do Mavorite.
Well, it's easier to get them to do something for 8 weeks than it is for 12. So
Well said.
Yeah, this is Kaylee. I was going to just agree with everything that was said already, but yeah, I would agree with the 8 weeks too, just so you can get them through the course a little bit faster. And you probably don't even need, if the main issue is that he doesn't, he's hard to kind of track down to get labs on. I mean, really, as long as you have the SVR12, I mean, I like to do a treatment week 4 profile just so that you can, repeat his liver enzymes, make sure they've normalized. And I just like to check an HCV PCR on treatment just so that you have that trend in case they do fall out of care and then, follow up some years later with virus again. It's kind of nice to have that trend while they're on treatment to help delineate between reinfection and treatment failure. But I mean, really, the only labs that you would absolutely need would be the SVR12. So that may make it a little bit more feasible to him if he's not really wanting to come in more often.
well, he's pretty compliant because he's we're primary care with him. So we manage his sugar and blood pressure. So he's I think that him I won't have a problem with. Now some of these others I'll probably have to chase.
Fair enough. Thanks, Mandy.
You're welcome.
Thank you all so much for the recommendations and comments. Amanda, did you have any other questions about this case in particular?
No, it was just his medicines. I didn't know if we were going to change anything with what he was taking. It didn't look like we were, but I just wanted to hear that it would be okay. So.
Absolutely. Awesome. Sounds good. Thank you. So if you're ready, I'll just pull up your second case. Alrighty, I'll turn it to you.
This is another 45-year-old male that was inpatient with Southern Highlands that we work with. He's, been clean for a while, but having a hard time staying that way. He keeps relapsing. He's been inpatient now, I think almost 90 days, but he hasn't had any IV drug use or anything in more than 3 years. He's got a job now and a good support system at home, so he's doing better than what he was the last time he tried to get treatment. But this time when they did his labs and stuff for inpatient, he came back with the diagnosis of Hep C. So he wanted to get treated and get on with his life. And I'm hoping that he can continue to do as good as he's doing now. So he didn't really have anything significant. We are seeing him pretty regular. He's coming for his follow-ups. He's done his vaccine follow-ups and stuff like he's supposed to. He is scheduled for an ultrasound as well because he was at F1, F2. And it's the same thing with him. I'm looking at August. The hospital down here is just backed up. I don't know if they don't have any help, but it's the same issue. Can't really get him scheduled. His viral load was high too. So with him being that high and then trying to do the fibrosis stage, we thought that he would need the ultrasound. Just from the last recent calls we've done and the cases that we had presented before that. He had a MELD score of 6, and other than that, I didn't really see too much on him either. We did put him on vitamin D treatment because vitamin D was so low. He's been taking that now for more than 30 days. So we just thought that Maverick would be the easiest choice for him too, because of the way he works. And I know he needs to eat with that medicine. So I always like that one.
Thanks, Mandy. All right, any questions about this case?
Is he a smoker? Do you know?
Yes, he does smoke. Actually, I think it's that he is dips tobacco more than smokes because of his job.
His hemoglobin's high. And
Yeah.
I always like to show people that. I'm like, see, your body's suffocating. But
Yeah, he I think he uses the snuff pouches, actually, is what he said. The Copenhagen, I believe, who makes those.
well, I don't have any argument about the smoking then. I don't know what's up with his hemoglobin. Maybe he just I don't know.
Well, you know, he's probably smoking too when he's not in.
Hey, Mandy, this is just a general question, not necessarily specific to him, but how much do you or how much does your practice, do they counsel patients on harm reduction?
Yes. Well, we don't per se. Southern Highlands does. When they're inpatient like that, they go to group, I think every day. And then when they come out, they try to put them in either an outpatient sub program or kind of like if they don't have anywhere to go, they're really good about placing them in the area so they can still stay with the same counselors that they've had.
Gotcha. Okay. I just asked that. I think the second half of the year, I want to do a talk on kind of risk reduction or harm reduction outside of, I guess, MAT, because I know a lot of our providers on here prescribe anyway. But I mean, the little things that I would just say, just generally with primary care, you know, I would opt to offer every patient with a history of substance use or Hep C or viral hepatitis, HIV, anything, just offer them Narcan with several refills, even if they've been sober for a while. I know this gentleman's had some relapses, but you know, the highest time of overdose is if someone's been sober for a little while and then has a relapse, is when they're more likely to overdose. And I try to tell people that too, just that you want to give them those resources. And even if they don't need it, to go ahead and refill it and hand it out to friends, family, just so we can get more members of the community access to life-saving medication like naloxone. And then I also try to tell patients too that, you know, 90% probably over of the drug supply anymore in West Virginia has fentanyl in it, regardless of what they think they're using, even if it's smoking marijuana. They we're seeing just such high amounts that basically everything should be considered, even if they don't ever report opioid use. Meth, cocaine, has been adulterated with fentanyl. So that's why I try to get Narcan in everybody's hands, let them know that and those kind of risks. And then, and we'll talk in July too, but just about kind of harm reduction in terms of, if they are injecting, how to clean out their works and those kind of little things that I don't really think anybody else will talk to them about, even if they're in an MAT program or follow with a counselor. But there's little things that we can just kind of tidbits just to help our patients through those kind of things. I agree. I think it's important he gets an ultrasound at some point. Again, I don't think you should wait to delay treatment if he's itching to get started until you have the ultrasound, but because he has stage 1 to 2, more importantly, because he has some baseline transaminitis as well, I think it's reasonable to also get an imaging modality. I would agree, you could do Maverick with him. I don't see any reason that you couldn't do either Maverick or Epclusa, but either one would be fine. Maverick for 8 weeks, I think would be certainly reasonable. And the other thing I wanted to point out is just remember that the degree of hep C viremia does not correlate with disease progression or infectivity or prognosis. It's very high viral replication. So you could take 2 measurements back to back and have a very wide range of viremia. So some people get a little bit worried if they see that their hep C numbers have gone significantly up. The only times that degree actually matters is if you're trending for spontaneous clearance, or if you're trending while they're on treatment and watching it go from viremia to undetectable. If they're pregnant and their viral load's greater than 10 million, then there's a slightly higher risk of vertical transmission from mom to baby. And then in certain instances, particularly if we are using Harvoni, you can use a shortened treatment duration if they have a viral load less than 6 million. So other than that, I mean, those are just kind of 4 instances that it actually matters. But other than that, the degree of viremia isn't too useful to trend. Okay. But thank you for presenting all these cases today.
Oh, Lord.
You're a rock star.
No, let's not say that now.
We always appreciate it, though. I'm happy you're getting people treated.
Oh, yeah, we've got quite a bit. That program, there is a program locally here that goes out into the community and does Narcan training. And they do open HIV hepatitis testing. And I'm not sure exactly what the name of it is. We went to a fair and ended up running into them last year. But they are in the community getting Narcan out there. And I know that our sub-provider writes Narcan to all the patients that we prescribe to, just in case they run up on something. So
thank goodness. I love it. I love hearing that. I really, really do. Thanks for sharing that, because that makes me feel good when I know people are on the ground working to help that,
yeah, they're based out of Mercer County, but I think they do Mercer, Wyoming, and McDowell. So
good. Awesome. Okay. Thanks.
Thank you for those comments, Kaylee. Thanks, Mandy. Any other comments, questions about this case from the group? All right, and Amanda, any other questions about this case you want to discuss?
no, those 2 were the easy ones. The last one.
All right, well, let's bring it on.
Last one is the one that is where we start with immunity and all that stuff.
All right, we're ready for you. Thank you.
This is another male in the area. He's 43 years old. He's had a heavy history of substance and IV drug use. He is currently inpatient and has been inpatient and sober since 12 of 22 that we know of right now. He was diagnosed in 98 and had no treatment up until now to even consider doing it, obviously, because he was actively using and just wasn't concerned. He is supposed to be transitioning into like a halfway house kind of thing, I guess, where they help him have a place to be and get a job and all that stuff. So he's getting ready to graduate from the inpatient program So I'm hoping that he's still well behaved when he goes over there, as he has been inpatient. He did have like iron deficiency anemia and the vitamin D, which we started him on. He was the one that was had HBV total positive, but his IgM was negative. So he's immune to Hep A and Hep B, but both of them are from exposure, from what I can tell. He was the same thing with the Hep A. His total was positive, but the IgM was negative, with the Hep C on top of that. So he's just, his MELD score was only 6, but his liver enzymes were elevated the last time that we had drew them. And he's a genotype 2B, which I haven't seen a whole lot of, so I wasn't really sure. But his fibrosis score was 0, so I don't know how he managed to do that with everything else that he's got. So we were thinking that Maverick would be the best treatment for him, just because of his history and trying to get him treated as fast as possible, since he has had this since 1998 and not tried to do anything with it. I know the last call we did, there was concern about the Hep B being a problem, where he was, had it in the past, but he cleared it. So I just wanted to make sure that was the right choice of medicine.
Excellent. Thanks, Mandy. And I'm not a clinician, but I can even tell this one's definitely more complex than the other two.
I think to save the best one for you.
Yeah. Best for last, exactly. All right. Any questions, comments about this case before any recommendations or feedback?
Just a question.
Oh, go ahead, John.
Oh, I was just gonna ask if his iron deficiency anemia got worked up, because that's a giant red flag in a 43-year-old male. There's something wrong with him.
Yeah, well, we put him on iron and he's been following up, but he's another one that is hard to wrangle. Even being impatient, they, when we checked his iron stuff the last time in February, iron was normal, but his TIBC was high and the UIBC was high too. But his iron saturation was only 8. She had a kidney ultrasound ordered for him, but I don't have any results in there for that.
Has he seen GI or any occult, hemoccult stool testing or anything like that?
No, not that I'm aware of. When they're inpatient like that, they kind of want us to wait until they're where he's going now to be able to schedule appointments and stuff. It's hard for them to get them to their appointments with transportation, because I think they have to have a nurse accompanying them and stay with them the whole time. So they kind of want us to wait until they can either graduate or get more stable before we refer them out to anybody. But if you think that he needs to see GI and get that going, then we'll definitely get that started.
It's I don't know an association with, and I didn't PubMed it to see if there is one, but chronic hepatitis and various cell lines do have a relationship. Often you see low white blood cells when you're cirrhotic, and low platelet counts can either be from cirrhosis or immune mediated ITP. I don't understand why he's a young guy. His hemoglobin is 14. That's okay. Maybe on the lower end, but then the iron deficiency is just kind of sketchy. I don't get it. We used to see a lot of anemia with Hep C from the treatment, from the ribavirin and interferon, but that's obviously old school stuff. But yeah, it just worries me. Unrelated, it's not a usual extrahepatic manifestation that I can write off. Normally we talk about iron overload with Hep C patients. If anything, we see elevated, stuff. But it just makes you worried there's something else going on. 43-year-olds can get GI malignancies, and if he drinks or anything, you can get ulcers, whatever. But anyway, not worried about infection, but I open that to the floor, see if anyone else has any more wisdom. But yeah, iron deficiency, certainly iron's a patch for it, but it's the why that you always worry about.
Yeah, and see his CBC when we drew it in January, like his white blood cell count and stuff was normal, and hemoglobin and H was fine. But, it was other stuff that was elevated, like his red blood cell count was up, and, the MCV and MHC were elevated, RDW was elevated, but then his platelets were normal. So, it's just, I don't know. He's got more going on, I think, than just having in and out. But he hasn't taken care of himself. So I'm hoping that getting this started and getting him treated will be the first step in that.
We have some fresh boarded internal medicine docs on John or Jackie, you have any comments? If not, it's okay. I don't want to put you on the spot, but I wasn't sure if you had any comments about iron deficiency anemia workup. Or if he needs anything more.
I mean, as somebody with far too much personal experience with colorectal cancer, and as somebody who snuck in before the screening, I would definitely recommend that sooner rather than later. With a significant, go get that looked at.
Okay.
Since he is inpatient and it's harder to get him scoped, or probably with GI sooner than later, are you able to just send occult stool tests to them, and then maybe do the fit test just to see what
Yeah.
that shows in the
And
meantime?
if they'll see, it's weird. They've got nurses over there, but it's like they I don't know, they don't like to nurse.
That's fair. Okay.
You know what I mean? There's nurses over there, but the stuff that we would do here, like if they ask for stool cards or fit tests or whatever, we could take care of that. Yeah, you start handing them stuff like that and cups for stool cultures or whatever, they get all nervous and they're like, so
Which hospital is he at?
I'm sorry, what?
Which hospital is he in?
It's Southern Highlands. They have like a mini outpatient clinics. He is in the Legends program here at
Okay.
Princeton. So he'll see Dr. Patel. He's the only GI we've got in the area. Yeah.
So, from his hepatitis standpoint, he's kind of demonstrating he's one of these chronic non-progressors. That's sort of a term that I steal from HIV. But, he's had 20 years of disease probably, and no fibrosis, which is awesome. He's got a funny genotype, a 2B, but it means we're limited in our treatment options to Mavorite or Epclusa. But they do well. So as opposed to genotype 3, which Kaylee and I don't really like because they're harder to treat and more rapid fibrosis. Genotype 2 doesn't really have that stuff. But it would suck to treat his hep C, get it cured, and then he has a colon cancer. So I just don't want to ignore the other one. Doesn't say you have to not treat him or even wait, but I just don't want to ignore the other red flag going on. And any other thoughts on him, Kaylee? I don't know if he needs anything special otherwise. I didn't look at his drugs.
No, not from what I can tell. I don't see anything with his drug profile, and either Mavorite or Epclusa. And I second what you said about his genotype 2, which we don't see it as much as 1 or 3, but that is the one. Mandy, you pointed it out without pointing it out, but that you said you didn't know how he made it that long without having any disease progression, and genotype 2 tends to be the least virulent. So we do tend to see that, and likely even aside from everything else like forward transmission and wanting to get him treated regardless, we do tend to see even if you never address the hepatitis C, if you're genotype 2, you likely will not have any progression. And so, so that's the good one to have. And with the treatments we use now, even though they all have very high response rates, but genotype 2, we see 100% with the study data. It's 99 and 100% cure rates. So even, very, very high. The other thing I know you mentioned was about the Hep B, and just some questions about that. Now, my understanding, you said his surface antigen was negative, and then core antibody total was positive.
No, he was surface B antibodies were reactive, but he hadn't never been vaccinated. So we had just assumed that it was because he was exposed and had cleared it naturally, I guess.
And so you have the surface antibody reactive and then the core total antibody reactive.
Yes.
Okay. Yeah. So you're exactly right. So that's consistent with natural exposure and good immune control. He's not somebody that I would worry about flare.
Okay.
So he has good immune control from that reactivating because of that positive surface antibody. So I wouldn't worry about him reactivating. The only like side piece of information that I try to tell patients that have a history of Hep B, even if it's not active, is just to be aware of that and that it likely won't reactivate, but just to make sure that he's letting his healthcare providers know moving forward of his Hep B history, because certain medications, even though not Hep C treatment, but certain medications could potentially induce a flare, like high dose steroids or long-term steroids, certain immune suppression agents like rituximab or certain chemotherapy. So it's still important for him to make sure that he understands that that's part of his health history, even though he's one of the ones that has a fairly low chance of ever reactivating.
Okay.
Thank you, everyone. Any other comments, recommendations? And Mandy, any other questions about this case?
No. Like I said, that last one was the worst one. The
Yeah.
other two were just simple. But boy, do I got doozy for y'all next time. So just wait.
Yeah, exactly. And I think we actually next time have a session of all cases too. So bring him in. I second what Kaylee said earlier. You are a rock star for treating all these patients, and we so appreciate you coming today and just pushing through all these case presentations. So thank you.
Well, Robin is much better at it than I am. So
No, you're both awesome.
Oh, you did great.
Yeah, I agree.
No, you're amazing, Mandy. We're so thankful, and no, she's not better than you. You guys are both wonderful. So we so much appreciate it. Truly, you guys are making a world of difference for these patients.
well, I will have y'all know that all the answers I get come from y'all. I really do listen. So
I know you guys are all so wonderful. Our hub members, our participants, the presenters all around, like that. It's such a great group and just so encouraging and positive, which I love. I mean, everyone loves that kind of environment, but especially like this and this setting, it's really nice to see. So gratitude to each and every one of you on this call. Thank you. All right, well, I can end the session 15 minutes early, give you guys back 15 minutes to your day. Unless there's something else you'd all like to discuss, you're always welcome to do that as well. So I'll just do a little echo pause here in case there is something anyone would like to bring up.
Yeah, this is Kelly Fournier. I have a question. What is the appropriate time post-treatment to recheck their viral load? Because I'm getting messages from a couple of the Medicaid things about this one was done too early or this one wait.
Great question, Dr. Fournier. So the cure labs, and I say that in quotations, but the documentation that Medicaid wants is 12 weeks, at least 12 weeks post-treatment. So when they post-treatment completion.
Okay.
So that's SVR12 data. So the sustained virologic response data obtained 12 weeks after they finish treatment. That's the only data that Medicaid cares about necessarily, I guess, with lack of better way to say it, because that's anything after that period, so at 12 weeks post-treatment or later, that's what they want to really document virologic response. So I mean, I typically check at treatment week 4, and then if it's already negative or undetectable or close to that, then I tend to not recheck it again until that SVR12. But yeah, if you check it at the end of treatment and send that off to them, they're going to still want you to repeat it again at 12 weeks post.
Okay. Thank you.
That's correct, if it helps at all, because we're the ones.
Yeah.
It's actually data collection for the Bureau for Public Health. So they're asking us to collect that so that they know how much goes into retreatment and how much doesn't. So
Okay.
it helps that you send it in for sure.
Okay,
Thanks,
makes
Angie.
sense.
That's what I meant is for lack of a better way to say it. I knew you would say it a lot better, but yes, they need that that data to monitor, reinfection, retreatment. And so
Yeah.
it's important to have that. If they don't come back for that, it may jeopardize, their retreatment options.
Yeah.
Or sometimes, if they don't come right back at that 12 weeks, maybe they'll pop back up at 2 months or 6 months, still grab it then, and that can be sent off at that time, but it's got to be at least 12 weeks after they finished.
Okay. Appreciate it.
Thank you for that question, Dr. Fournier. And thank you all for the responses. Anything else from the group? Alrighty, well, thank you all so much. Thank you again, Mandy, for all the cases, and we look forward to the other cases that are upcoming as well from you. So
Oh, yes.
big shout out to you.
Thanks, guys. Hope you have a good day.
Thank you, you all as well. Only announcement is that the next session will be on June 8th, and it'll be a session of all cases. Thanks, everyone. Have a
Thank you,
wonderful
guys.
rest of your day.
Thank
Bye.
As well.
Bye.
Bye-bye.
Bye, guys.